Welcome. This is the Institute of Health and Social Care Management, and this is our combined health and social care, digital health and digital technology special interest group meeting for April. We're delighted to welcome David Kwo and Tom Bell, who are going to be discussing the thorny issue of are ICBs the opportunity to finally crack the digital nut. I'm intrigued, gentlemen. I'm going to leave it to you, and then we'll have I guess we're going to have a discussion time for this when you finished your presentation. Perfect. Off you go, guys. I'll hand straight over to you.
Thank you, John. I'll just introduce the agenda and then quickly hand over to Tom. For those who don't know me, I'm a digital health kind of practitioner. I've been in digital health for over 30 years in and around the NHS, and I'm also the chair of the IHSCM Digital Special Interest Group, this one. So today, our ICB is the opportunity to finally crack the digital nut, as John mentioned, and we are proposing to have a very simple agenda because we really want to engender discussion. So after our introductions, Tom's going to start us off with giving the context, culture, and opportunities around ICBs. I'm going to follow with really just a few questions and comments around ICB digital landscape and opportunities. Again, to hopefully set up a wider discussion and make it really interactive. So, Tom, over to you.
Thank you very much, David. Do I have control? He said. I've never had control. I do. Thank you. So, slightly more different title than I was going to use the title "What the Facts," but I thought that might be a little bit too much. So I think there is an opportunity here to use ICSs and ICBs to finally crack the digital healthcare nut. So why am I on this call? Shameless plug here. For those of you that haven't read either of these books, you can find them on my website. No Wealth But Life was published last year on the 75th anniversary of the NHS. And The Killing of Alison is all about my sister and what happened to her many years ago in the care of the NHS. I've lost... Oh, no, we have there. That's me. That's my website. My mouth doesn't always look like that, by the way. That's just the way it takes the screenshot. So, question. What business is the NHS in? And there's the answer, as far as I see it. At its heart, fundamentally, it has two products, and that's the business that it's in. It's a services business and an information business. And that information, it's a services business by default. It doesn't manufacture vehicles. It doesn't manufacture widgets. It provides services. And the information part of the business is the bit that enables it to provide those services effectively. So I'm having fun with the controls here. So let me just ask another question here. I always find it interesting when governments or whoever it might be, will somebody please stop clicking the thing there?
Sorry.
That's okay. Does a system become integrated because you call it integrated? It's a great political soundbite, isn't it? We've now got integrated care systems. Right, David? Hands off the keyboard, please. Right.
Just turn this chat off, that's all. Sorry, go on.
Okay. So the answer is that it only becomes integrated when it's able to effectively coordinate its resource and efforts. You can call it integrated until you are blue in the face, but unless it behaves in an integrated fashion and provides integrated services, calling it integrated care system, calling it an integrated care board is just a name change, unless you've provided the infrastructure and the means, and there's the will behind it and the resources behind it, however you define resources, whether that's people, whether it's cash, whether it's IT infrastructure, etc. That's the thing. It won't become, and for many patients, I don't think it matters what you call something. We don't, I don't ever think of Amazon or Google as integrated providers of the services they provide. They just are. It just happens. I don't think anybody's ever come out of their GP practice after a visit there saying, that was a seamless integrated care experience and I felt that it was customer centric. They just don't think that way. It either is or it isn't. In the private sector, of course, you don't call those things. You vote with your feet and you walk in and out of those things that meet your requirements. So if that answer made sense, then what's the critical success factor that would enable that? So if we're saying that the key to becoming an integrated care system, truly integrated, is that you are integrated in the sense that you are providing easy access to all the relevant information that's required by all the component parts of the system, then what's the critical success factor that you need for that? And that's it. Now, in the days of, slate tablets or pen and paper, this would have been done differently. But whether it's running the NHS or whether it's running a regiment in the army or running an entire army or running an entire department or a company, you have to provide all the parts of the system with easy access to relevant information and data. And there's no better example of this than the story that many of you will have heard that came from the First World War, where the breakdown in communications was that somebody said send reinforcements, and that was eventually interpreted as, send 3 and 4 pence. The IT enables us to send information in a much clearer fashion than we've ever been able to do before. But that you have to provide all parts of the system with easy access to relevant information and data. Now, I say that as a chartered marketer. I was a chartered marketer for 20 years. And the mantra of marketing was that the more you knew about your customers, the more you could sell them. And in medical terms, what that means is the more you know about your patients and the faster you know it, the better you can treat them. It translates very simply into that principle. It also means you're providing the best service for your patients, and you're taking the resources within the system and you're using them optimally. Because if you know what you need to do when you need to do it, and people have access to the information that they need to do the jobs that they do, that kind of makes sense. And in the private sector, you'd say that was motherhood and apple pie, yeah? And we're going to come on to that soon. So if that's the case, if it is the case that you provide that, how can it be enabled? So we're going to have a not quite role play here, but I'm going to invite you all into an imaginary exercise, yeah? So we're all on the board of a new institution, and this new institution that's been created is tasked with the very important job of providing an essential product to the citizens of an entire nation, yeah? And so we've gone out to a focus group and we've come up with the name of our new company. Yeah, this is the McSain's Goo Amers Health Company Incorporated. It's a terrible name, but that's what user groups do, isn't it? They always, a camel is a horse designed by a committee, isn't it? And what we are is that we've acknowledged that we're a user-centered services business, and we're based on a hub and spoke model. And our mantra is easy access to relevant services for all customers. It's a simple mantra, isn't it? But actually, if you look at some of the most successful companies in the world, it's the mantra that they live by. That's how they survive. That's how they provide services effectively. They give easy access to relevant services for all their customers. And I'll bring that to life with an example I think we can all identify with, which is if you look at banking, yeah. So back in the day, when I was a youngster, in my early 20s, I had a job which involved me working away. And what would happen is every Friday afternoon, I would go to an office in Altrincham. And I live 90 miles north of Altrincham in a little town called Penrith on the edge of the Lake District in Cumbria. And what I would do is I would be selling contracts to people. And on that Friday afternoon, I would go into the head office where the boss would sign off the contracts and pay me on what I'd done that week. So this was, we're going back in the days where trying to get a well-paid job was a difficult thing to do. I guess it probably is even more so now. And so youngsters like me who had mortgages, we had to try these things. And what I would then do is I would take that check that I'd been given and I would drive all the way up the M6 as fast as I could without getting caught. And I'd try to get to the local branch of the TSB Bank, which was the only branch that would accept my check, because the branches in Manchester wouldn't accept the check because I didn't have my local account with them. And so I'd get there. And even if they did accept it, they wouldn't then cash it in time for me to use it. So I'd get to my local branch of the TSB Bank in Penrith just in time for 6 o'clock, and I'd cash my check. Great. As soon as First Direct became available on the banking market, and some of you may remember, some of you may be of an age as I am, that you can remember when First Direct launched its online banking services into the marketplace, that changed everything. That was called phone banking, telephone banking. It wasn't online back then, but I could ring them up and I could do things. And all of a sudden that was so liberating for me. And so when I talk about easy access to relevant services, what I had there was this strange thing going on where I had a branch of the TSB on my high street in this small town of Penrith, which was now less relevant to me than a service based in Leeds, because the service based in Leeds made itself available to me at times to suit me and in a way that suited me using the channel of the telephone. Simple. Just as we now use online banking on our smartphones. So what we're going to do as the new board of this company, that's our mantra. We're going to consider two possible options now to equip this new company with the IT infrastructure that it needs, because we've decided that the competence this organization needs is to be able to share information within itself, which makes the service more effective for the staff within it and makes what it provides better for its customers. So we're on board with that. So what we're going to do is we've got two alternative strategies. One is, by the way, we've got all the best chief execs on this, right? We've pulled them in from Google. We've got Larry Page, we've got Sergey Brin, we've got Jeff Bezos, we've got Dyson on the board, and we've even resurrected some of the old management gurus of the past. So we've pulled up Peter Drucker from his grave, and we've got all these people who understand the principles of delivering a good service. And we've got two strategies that they're considering. One is somebody's come up with the idea that we say to this new organization that we've got, which has employed about 1 million staff. So we've got a great budget. We've employed 1 million staff. And what we're going to do is we're going to say to them, gather yourselves into groups and you decide what IT you want to use, where you want to use it. Whatever you do will be fine. It'll all work out in the end, yeah. What we say is we say, off you go. They go off into the open marketplace and they can work with any IT suppliers that they want. They can buy any technology that they want. They can use any tablets that they want. They can use any standards that they want. They can use any internet browsers that they want. They can create their own apps. They can do all kinds of things. Off they can go. As long as they do something, then we're not too worried about it. The other strategy, which is the one that's preferred by all those top execs that we've hired into advisors, the other strategy is that we set the direction of travel at the centre. And the reason that we do that is that we've had this market research project going on, and it's the longest running market research project in history. It's been going on for 75 years. And what it's done is it's given us a lot of data about what people want, where they want it, where they need it, what their services they require from this new provider are. And the board of our experienced, successful execs is telling us that what we should do is set direction centrally, set standards centrally, be consistent, and that we should implement a system that works within itself, connects to itself, provides everyone within it with the same consistent access to information, whether they are in Aberdeen, Aberdare, wherever that is, or whether they're in London, Suffolk, Penrith, Exeter, Southend-on-Sea, so that all the component parts of the system, the mental health practitioners, the acute services, the ambulance services, the primary care or GP practice services as we know them, that deal with over 90% of demand, they've all got access to the same core information that every other part of the system has got. And that will therefore enable them to provide the customers with that seamless, easy access to relevant services. Which path do we go down? Do we say, let's provide a consistent IT service that works within itself, that talks to itself, that communicates with itself, that is accessible by the people that need it? Or do we just say to the regions, as we call them, go off and do your own thing, and let's see how it will all work out? That's the question that I will throw up in the air. And on that note, I will hand back to David, who has some fabulous thoughts that I know he wants to share with you.
Thank you so much, Tom. So I'm so glad Tom framed it in that way that he did, because it kind of leads me perfectly to the thoughts that I'd like to offer. Because I'm going to focus a little bit more on digital. I'm going to do what I don't normally do in these circumstances, which is kind of show a lot of pretty slides, because I kind of want to step back with with the questions that Tom has just posed in your mind, I'd like to suggest a couple of more complementary questions. Okay. And so, like Tom, the way I use different words for the same sentiment and same sense of frustration, which is, I believe, and I hope many on this chat, in this group will agree with me. I believe that the NHS lacks a coherent overall digital vision. And of course, whenever I say NHS, I do mean NHS and social care. Now, I happen to think there are two main reasons for this lack of coherent vision. I think we have, if I might call it, some chaotic or dissonant, conflicting mindsets. Two mindsets I'd like to highlight. One is mindsets amongst our leadership, as Tom touched upon. So what do I mean by that? Well, the way I've seen it, and I've worked for, many NHS trusts over the past few decades and worked with a lot of NHS trust leaders, I still think, including NHSE and at trust level, I think there is kind of chaotic, incoherent view on what's important. What are the priorities? Because currently, we all know, and it has been for a long time, performance and waiting lists. We read about this every day in the papers. Productivity is, equally important for NHSE and trust boards and chief execs. Witness the elective recovery fund as an incentive to fix throughput and elective waiting lists. Financial recovery, of course, and deficits. And the other problem with leadership mindsets I witness, I think many of us do, is what I term the sovereign trust versus the system tension. So I think we often hear trust leaders now saying, well, yes, we're a sovereign trust, but we want to transition to ICS system thinking. And I hear this a lot from chief execs now. But I note here, I don't know if anyone caught this, but yesterday there was a publication, and it was highlighted in the HSJ, about a new regime that's coming on stream. It's not there yet, to do with ICB ratings. Okay, well, I had a little look at this ICP ratings thing, and I tell you what, it kind of reinforces silo thinking, because I tell you, unless I didn't catch it, there isn't one measure on this proposed ICB rating system that measures how an ICB delivers integrated care from the perspective of the patient, which to me, in my humble opinion, is what an ICB is about. Okay, let me keep going. The other problem with what I call chaotic leadership mindsets is I don't believe our leaders join up the dots. And what I mean by that, just to give you an example, is, I've worked with a lot of boards, and they continue to wring their hands every board meeting, every month, around performance and waiting lists and deficits. They don't talk about their EPR programs after the EPR has gone live. Okay, the EPR is a flurry of interest, and then it kind of recedes from importance. And I think that's a mistake, because I think we all here probably believe that digital has a lot to offer some of these main board agenda items, but the boards haven't picked that up yet. I also believe that our NHS leaders are a bit too reactive. So it's like, what's the new shiny object? What's the new sweet, in the what's the next sweet in the sweet shop? Because they get swayed by, oh, AI is the solution. Oh, the NHS app is the solution. Oh, the new federated data platform is the solution. Oh, virtual wards are the solution. I mean, I could go on and on. Okay. And they just get swayed from one to the other. All right. So those are kind of my moans, my frustrations anyway, around NHS leaders and the way they think. It's just not coherent. Let me carry on to digital. Okay, well, I recognize 4 distinct schools of thought in the world of NHS digital. And I really want to invite a conversation about this because I'm not sure if this is correct, but let me just put this forward. And I think because there are 4 incoherent, dissonant schools of thought, there's a conflict. That's what I mean by chaos. So the first one is free the data. Okay, we've heard this, yes. So there's been a huge movement published around, well, what we should do is rise above all the chaos of different EPR systems, GP and hospital, Cerner, EMIS, Epic, let's rise above all that. Let's not dirty our hands with all that and just get them to give us the data that they hold in their systems. And we'll just use the data in some federated data platform in a separate location that we all, whoever this we is, have control over. So we free ourselves from the shackles of these terrible private companies. OpenAir is one of these communities that advocates this. It's been supported by EY, and we know KPMG now has been being paid £8.5 million to promote FDP usage. All right, there's another school of thought which says, well, what's really important is we need to level up the maturity of our hospitals with EPRs because only 60% or some smaller percentage of our hospitals have an EPR or on their way to an EPR. I think that percentage is rising, but the point is there's central funding and initiatives. There are now tiger teams, so-called, being more consultancies being commissioned to help implement EPR. So this mindset is all about, well, the answer to digital and health is wang these EPRs into trusts. Okay. There's the third school of thought, which is, well, let's run a lot of digital programs. I think quite like the other school of thought, the other option for the board that Tom posed. This is the Thousand Flowers Bloom school of thought. Yeah. So this says, let's run a lot of important digital programs. One of them, of course, as we've all heard, is bed management systems. Every trust has to have a bed management system. Let's put all our eggs in the NHS app basket, which our chancellor and I think both and West Streeting, they both believe that they have that in common as something to do. Virtual wards, and there are other programs that we can name. Then let's not forget the fourth school of thought that I recognize is shared care records. So to kind of do what Tom posed, which is this NHS business that we are all part of should have information, shouldn't it? That's kind of integrated. And well, shared care records do that, don't they? Or do they? But anyway, let's not debate that right now. The only point I really want to make here is that I see at least 4 distinct schools of thought, prevailing schools of thought, which have a lot of sway in terms of what the NHS is actually investing money in, money and time and attention. So, okay, so I, for one, am frustrated by these different schools of thought, freeing the data, EPRs, a variety of programs, shared care records. Just to give 4 examples, I think there are probably other schools of thought. But these are the main ones that I currently grapple with. I actually don't have a kind of coherent solution that I can kind of overlay to all of these schools of thought and say, well, this is how they would fit together in a coherent way, because I don't think that's possible. Okay, let me just move on. So I'm very frustrated by chaotic mindsets of our leaders and the digital community. And I don't think that's helping us achieve what Tom posed early on, which is to allow the NHS and social care to have one mechanism for free-flowing, accurate information. Okay, and then I'll just finish up by saying, well, there is, of course, I think we've mentioned this, there continues to be a silo mentality, which leads to silo investments, which perpetuates silo behavior, mitigating against integration. And so the other way of putting it is this: I don't think the NHS leaders and staff are pivoting, if I may put it this way, fast enough from the sovereign mentality to system mentality, even though there's talk about it, but no one's walking the talk. Okay, and then I just a few quick thoughts in terms of why I don't think things are going well. There is, this goes for all industries, but it's no less true for the NHS. I think there is not a good enough recognition of the difference between having good ideas and executing and delivering on them. And I say this because I've worked for so many trusts and leaders who just say, I mean, I worked for one recently, I will not name, you know, who's one of the chief executive officers said, well, to solve this problem, we just need to name somebody who can be in charge of this, delivering this project. Give me a name. Give me a name that I can make accountable for this project. As if, oh, by having the name, the project is instantly delivered. Okay, and that mentality is actually very pervasive. And I happen to think that's everyone's problem, not just trusts that I'm just gave you example of, but at all levels, and including suppliers, actually. And then I have a couple of key kind of almost pet topics, which I won't spend any time on, but I happen to think is very important to make this whole digital vision coherent for ICBs. I think ICBs need an enterprise architecture. Some of you may have heard me say this before, and every time I mention it, people say yes, 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 but I don't see it happening at ICB level. Data quality is one of my soapbox topics, which I think pervades all of these things. And what I mean by that is shared care records and FDP and other repository-based, and even the programs are all dependent upon good quality data from source. And the sources are GP systems and hospital EPR systems and so forth. And no one measures data quality or reports on it or manages it adequately, in my opinion. So, and then, okay, well, I'm just gonna kind of stop here. As I said, this is not my usual presentation mode. I tend to present a lot of pretty slides. I've decided not to do that because that's just kind of contributing to, this is my school of thought, and it's not stepping back and helping get around competing schools of thought. And so, as I've said here, I want us to try and do more, us as a community, to do more than just kind of moan and give opinions on what I think is the right digital solution, which is what we kind of go round and round doing. What I'd really like to do is to, first of all, check whether people here think my frustrations are kind of correct, or am I, have I got the wrong end of the stick? And if so, what can we do to get over the chaos, to together work towards coherence? And personally, I believe the best way to do it is somehow to have more genuine conversation. Okay, in other words, for instance, have a round table, have workshops, have conversations or debates where we have proponents of each of these different schools of thought. Give each some time to offer the evidence for their school of thought, for what they believe, and let other people see the evidence, because I don't think people kind of see the evidence enough. People kind of take in a position and they kind of stick with it. Okay, that's really all I wanted to say for my bit, because again, Tom and I really want to engender conversation, and that was the purpose of our introduction here. We want to engender conversation focused around ICBs and focused on what they should do, and focused around digital and how that can help the ICB mission. Going to end there. I do see Paul has raised his hand. Shall we start with Paul? Hello, Paul. How are you?
I'm fine, thank you, and a thoroughly interesting presentation from you both. I think Tom probably knows which way I would sway, and it's not through a control perspective, but it's just through scalability perspective. It has to be an overarching approach rather than a free-for-all. I think the free-for-all has demonstrated it simply does not work, yeah, on multiple levels. And I've lost your slide now. I was going to use that as a backstop. From John's point that he raised in the chat, there is a significant problem with senior leadership. The ICSs are funded by NHS England. They cannot be anything but biased. If they are funded from NHS England, they will have an NHS clinical perspective and the rest will go to the wall. Yeah. So it probably needs to be funded from Department of Health and Social Care rather than NHS. Okay. So secondly, the senior leaders within the ICSs and to some extent trusts. Firstly, the ICS do not have the wherewithal digitally to even comprehend something bigger than a silo-centric approach. They just don't. It's been demonstrated time and time again in the conversations I've had, in the meetings I've attended, in the webinars I've attended. They just don't get it. They talk a stunning game, by the way, but they just don't get it. And I guess the next bit is the mechanism. If we did have an overarching approach, if we did have something that could bring multiple facets together, I don't believe that whilst there are some very, very smart people in NHS and social care, it has always been driven by an NHS perspective, and it has always been driven by a clinical perspective. And so if you have clinical at the center of everything, the result will always be clinical. Yeah. So I would propose, just as a very high level, that instead of thinking of systems, think of repositories, data repositories. Yeah. Now, OpenEHR has a very good approach from a clinical perspective. That's fine. But there are absolute myriad of things that go beyond the clinical. And once we get into a repository perspective, we can then start having curators of those repositories. So in the clinical sense, you'd have your CCIOs and all the other good people within the NHS that would reside over that repository. They would be the custodians of that repository, and that repository wouldn't change that much unless somebody came out with a new idea. Once you have that repository, then you can say, well, okay, let's look at others. And I'll use social care as an example. You would have social care experts presiding over that repository. And when I say preside, they decide who gets access to the data. They decide the structure of the data. They will liaise with the clinical CCIOs, and they will not operate in silo. And once you have that mechanism, all this chitter chatter, all this nonsense and the time wasting and spending money across silo-centric ideas evaporates almost overnight. The NHS app will become nothing more than a recipient of data. And then to go back to David's point about cleanliness and quality of data, once we're in a repository type approach, we swing the focus away from silo, away from system mindset, and we start looking at how we can improve the quality of the data in each respective repository. And that is down to the responsibility of the people who are let's say the custodians of it, the curators of those systems. Yeah, they can't go rogue. It does require an overarching vision. The problem again, and I'll just bring it right back up to the top level, everybody talks a stunning game. There is nobody that I have spoken to has an overarching vision. Not one. And when you ask for one, the usual suspects gather round the table. It's always the usual suspects. It's the academics. It's the people in positions of power. And they have absolutely no idea of what goes on at the ground level. I'll stop there because I think a lot more people have got probably a good thing to say. But I think the repository approach, and we can cut out all of this political game playing with the big providers, the lobbying. Let the right people own these repositories and get rid of most of these big suppliers. Then you have the freedom to literally create an environment that suits you and suits your purpose. I'll stop there. Thank you very much, David.
Thank you, Paul. Loy, were you next or was it John? Sorry.
I'm
sure.
happy to wait for John to go if he wants to go first.
John, do you want to? John.
Oh, you go for it, Lloyd. Go on, mate.
All right.
Thank you, Loy.
I think it's instructive to look at what happens in other countries which are trying different things. I've been looking at India with interest for a while, not just because I'm originally from there. I still retain a lot of connections. For many years, when you spoke to an Indian hospital group and they said hospital information system, what they really meant was a billing system. But in the last 5 years, the Indian government has decided that every citizen in India needs access to their personal health record, including how much they paid for their healthcare and where the funds for that came from, so that where required, it can provide bursaries or grants for people who cannot afford healthcare. In order to achieve that, all it has done is to say, there's going to be a national repository, and you can publish data to it, and you can subscribe data from it with the consent of a patient. And all of the APIs are going to be FHIR compliant.
Why?
That's what they decided. Look, don't ask me why. I can connect you with people and they could give you an answer why, but they said we need a standard. We've decided that's what we're going to pick. And guys, just get on with it. Now, we can debate whether that's the right standard or not, whether that's the complete picture or not, whether that's the right design for it or not. But there's an important aspect to signaling a direction, because when you signal a direction, then instead of having competing forces all going off in random directions, everyone says, well, that's the way this country is going to go. If we have to participate, we need to follow that general direction. And then whatever extensions need to happen around it still need to align with it. And that, I think, helps focus minds and focus effort a lot more than what we are seeing currently pan out here in England or the wider UK.
That's helpful. I'd like to come back on it, but John, please, you've been patient.
Oh, that's all right. I'm interested listening to Lloyd's points, actually. I think Mary raised an interesting point about what are the ICBs for, or the ICSs, what are they for? When they were created, my understanding was that they were intended to design delivery of health and care that maximizes efficiency and effect based on regional need. And that tells me that they have to create a mechanism for finding out what is regional need, and that may be based on data, but it's also based on feedback from citizens in the community. And I think that's been the biggest void since that was all set up. If you look at, and I have looked at this, I've researched it, I've been on most of the ICB websites. Most of them are faceless, most of them are uncontactable, and as a result of that, I feel that most of them are uninterested in actually what the citizens of their region's experiences of health and care are and how that should be rectified. I would like, in a positive way, David and Tom, I would advocate that if we've got these ICBs, and they're not going anywhere in the near future, they've only just been introduced, irrespective of what a new government may do, you know, they're here for a while now. So I would just say to every ECB chief executive and C-suite board member, you should be mandated to undertake a series of town hall meetings where you go along, you set out at a local level what your integrated care strategy is in plain and simple English that people can properly understand. You invite contributions from citizens, community groups, and other interested parties, and you demonstrate that you've listened because you take that information away and you demonstrably, clearly do something with it. And if we got to that, then I think we'd start to make a consistent improvement in the way that ICBs are being run and managed, and the efficiencies they should be creating could be judged. But at the moment, it's just silence. They're just, as I said, faceless, uncontactable, and as a result of that, most people feel that they're uninterested. That's my view.
Okay, I'd like to come back on that as well, but Richard, please.
Hi there, David. Good to see you again. How are you, sir? All right.
Hi,
But I guess I overlap with something John just said, but I'm just interested, Tom, when you kicked off, you talked about information, and I was just interested in what your, so first of all, a question and then a couple of thoughts, but what's your description of information in that, in what you were outlining in your magic organization with its two approaches?
When I say that the NHS is a services and information business, let me try and bring that to life. So if you look at how NHS organisations are tasked with providing information to customers, yeah, there is, and this is why I put in the chat box, and kind of, I understand where Lloyd's coming from, but I put in the chat box that actually if you signal direction to the NHS, it achieves little. You know, we've got lots of experience of lots of signals being given, and it excuses the centre from doing anything, and it allows those on the outskirts to do what they want. But in answer to your question, Richard, information is every bit of information within that business. We can call it data, we can call it information, we can mix the two because the two are blurred. There isn't a clear boundary between the two. There's the qualitative, the quantitative, the anecdotal, the kind of stuff that would emerge from John's town hall meetings, and then there's the empirical stuff. What I mean is, at its most basic level, if you say what information do patients need to get the most from their care and to be the most effective patients, because there's a transaction here. I don't want to sound reductionist, but there's a transaction between a patient and the provider. Yeah. So in any healthcare system, whether it's the NHS or an American healthcare system, whatever it is, yeah, what's needed for the patient to access what they need when they need it. And if you look at the approach of NHS trusts and ICBs, who have been called, and I put that in the chat box, ICBs have been called the largest unelected quangos ever created in the UK. I think there's some truth in that. What are they saying that patients need? Because if I go to one trust and look at its website, and then another and look at its website, and one GP practice and look at its website, and another and look at its website, and again, I'll bring this to life with an example for you. A few years ago, I worked for University of Central Lancs, and we had this role where I managed to secure some funding, the princely sum of £10,000, quite what they thought they were going to achieve for that, I'm not sure. But the princely sum of £10,000 was given to us by NHS England to come up with a common standard for primary care websites. Yeah. So this is we're getting to the information piece of your question. So what's the information offer at the moment from primary care? Let's look at primary care because it deals with over 90% of demand. if you actually go to somebody and say, do they use their primary care website? The vast majority of people go, no, why would I? It's a kind of a static website. Looks like it was designed by somebody in the 90s using front page. Yeah. It's generally out of date. There's no way to contact the practice on it. In fact, that seems positively excluded. What it does is it gives me information about their opening times and yada, yada, blah, blah. It might point me to the NHS app. It might do a bit of this and a bit of that, depending on how developed the practice is, how large the practice is, whether it's got an IT manager or a decent practice manager, all that stuff. So from those just under 9,000 GP settings, there are, at the last count, there are over 500 different website providers, and there's no common standard for creating a practice website. So when I talk about information, that's the patient-facing, the user-facing information coming from primary care, which is lousy at the moment, utterly fragmented, utter rubbish. Then, so that's one of the external parts of the information bit. Yeah, then we look at patient information. That's different for every organisation. In fact, some of them have no budget for patient information. That, isn't that madness? If you were running a business, if I was, let's take an average trust turning over 200 million quid. Forgive me for getting a little bit on my soapbox, so I think it's a great question. If I was running an average trust, 200 million quid turnover, smallish trust, if I was running a services business with that turnover, and you said to me, Tom, what proportion of that do you commit to providing information to the people that need it? Then I would provide that information in a consistent way, and there would be millions of pounds committed to providing information. Some people might see that as a waste of money, but actually the provision of information to the right people that need it in the right places where they need it is incredibly effective. That's why the private sector does it. Private sector isn't known for wasting its money. Yet you look at the NHS and you say, right, and I've said this to many NHS trusts, what's your budget for patient information? And it ranges from, well, it's the department's responsibility to 3 and 6 to nothing, to, occasionally someone will say, yeah, we've got a decent central budget for that, but what does that mean? It's not user focused. Then if you look at the internal users of information, because the sum of the customer's transactions is in many respects influenced by how effective the internal transactions are within the company. And all those transactions depend on availability of information, yeah? So I jump in an ambulance. This is a true story. I jumped in an ambulance a few years ago. Well, truth is I was carried into the ambulance, yeah? That morning I'd been to my GP practice and I'd been given 3 inoculations to help me travel abroad, yeah? Apparently it's not usual to give those 3 all at once, but the practice nurse said, you'll be fine, slams them in, there you go. 5 hours later, I'm collapsed on the living room floor, haven't a clue what's going on. I can just get to the telephone and I ring emergency services, yeah. Well, actually, I rang my sister-in-law around the corner first, but when she saw me, she said, you need to ring an ambulance, right? So ambulance comes along, whisk me into the ambulance. There's no IT in the ambulance, right? They can't access what the GP, I'm trying to explain to them what I think I was inoculated for and what happened and what I think the cause of it might be. They can't access my records. So they're scribbling notes away. So I say to the nice lady that sat beside me in the ambulance, I say, do you not use an iPad for this kind of thing? And she said, oh, no, I wouldn't know how to use one of those, okay, which is, doesn't inspire confidence. So that's fine. Then the guy pipes up from the front. He's a nice ambulance driver from Poland. And he says, yes, we have more connected IT systems in Poland than you do over here. He said, it is slightly worrying. So then we get to the hospital and she hands some printed stuff to the consultant at accident and emergency who's waiting for me, which he then has to interpret. Nobody as yet has access to GP records. GP records aren't available at the acute setting. They're not available in the ambulance setting. So all those points of my journey, literal journey, 25 miles up the motorway, nobody has access to the information they need to understand what's actually happened to me. So from a marketing perspective, nobody understands what I've been sold, which then needs solving, yeah? And so when I talk about information, I talk about it very much in the round. I mean, it's a great question that you raised, but I mean, that whole information business, who's responsible for making sure the information within an NHS trust, within an ICB, lives in the right places and is accessible by the right people. And a great deal of that, of course, will come down to digitally enabled information. That was a bit rambling, but does it help, Richard?
It helps because at least you've filled a gap that I was worried about in your presentation, but it doesn't address the problem you highlight in the NHS. You described your organisation as a service organisation, and a service organisation inherently, any service organisation, involves the confusion and the complication about it is it involves the patient, the user, the customer inherently in the delivery of that service. There's no other way of doing it. And we don't talk in the NHS when we're thinking about data. When you went through your presentation, when David summarised so many things that are so true, We don't think about the patient. We don't provide the education. We have a saying here, an educated patient is a better case patient who makes less demand. But we do not think about that as part of the program. So I just wanted to pick up on, well, John got in ahead of me. I'm glad you've now referenced the point that there is no meaningful attention to information as it pertains to the user of a service, namely the patient. We don't think about it in a coherent way. And then my other point, keeping it really brief from my side, is what I see is a system that is now so broken, so fractured, so dysfunctional, so many conflicting interests and priorities, that even thinking about how we manage data is actually out of the bailiwick of anybody else, because unless we solve the underlying problems and behaviors in this organization, we ain't going anywhere. We can argue the toss about FTP versus open versus closed versus patient-held records versus MyBit, information for patients, and on it goes. But it is so broken now. And David, you touched on it. You were much more polite in a way that I'm being, but that's what you put on your slide.
Let me throw in very briefly then. Sorry, David, but I think one of the ways we could approach this, and this is why I think ICBs are an opportunity, is you find the worst ICB. This is the equivalent of Coventry Cathedral after the Blitz. Yeah, you find the one that is most needy, that you can start with ground zero almost, and then let's be honest. When people say let's map out, let's stakeholder, let's talk to people, I think a lot of people get bored with that, but I think it is important. We've had 75 years plus to get it right, still haven't got it right. So let's grab that broken ICB, whether you call it broken or needy, can't matter really. The words are unimportant in some respects. And you say, right, we're going to create a system for that region that works for its patients, which inherently means it works for its staff. And if it works for its staff, it works for its patients. In other words, you can't have one without the other, yeah? And that's the one that you use as your ground zero, as your test bed, your sandpit, your pilot, whatever you want to call it. I know we're all piloted out in the NHS, aren't we? And then you say, right, we create this from the ground up with the patient's needs in mind. And the patient's needs are also the system's needs, because again, those things aren't mutually exclusive. You can't have one without the other. And that's where you go with it. And there's no, pardon my French, there's no messing about, buggering about here. What we say is, right, we release the funding that's required for that. We don't know what that funding would be yet, but we release the funding for the initial research, the funding for the consultation, the stakeholder engagement, all that collation of information. We get people in there who are almost disinterested, who have no agenda, yeah, no axe to grind, who come up with the solution. And that, of course, that solution will evolve. It won't be set in stone. But then we say, right, we have something that works. That's the bit we scale up. That's the bit we roll out.
So I think so. So thanks, Tom. I think that's a logical and coherent way forward. But I'm conscious of the time. I do want to leave at least 4 minutes before we finish to try and agree next steps, which I'm hoping can be kind of deeper dive or anyway further conversations, at least amongst the people here that feel strongly about it. And I'm delighted to see that there are a number of people here who do feel strongly, even if the strength of feeling is around frustration. But I do want to quickly let Paul and Loy, say their piece. I also want to quickly touch upon great comments from Mary and Daniel. And then I want to try and suggest that we somehow get together again to continue this important and fascinating conversation. So I don't know who's first, but I'll pick Paul.
Thanks very much. Again, what you just said, Tom, resonates. Broken ICS, poor ICS, whatever. We could go down to a single hospital, a single social care local authority, a single care home, and the same applies. But the thing is, the moment you look at any of these, they all go for the established solutions. They never, ever look anywhere outside of that, because this is, oh, well, thousands of other people have done it before, therefore I'm not putting my head above the parapet. if we could actually divorce ourselves away from the current structures
Right.
and say, hey, let's formulate a digital approach that we can then overlay an ICS or overlay a hospital or overlay any type of structure, and that model should be robust enough to accommodate any structure that you want to throw at it. And
Okay.
I've been working on this now for 8 years. I have got some massive, massive thoughts on this. And I never, ever get an opportunity, perhaps because I'm so vociferous, I never get an opportunity to actually present this. I've applied to go on to TEDx NHS because my frustration, whilst palpable, is almost at boiling point. Thanks very much.
Okay. Thanks, Paul. Lloyd, please.
So I'd like to give Paul and whoever else that opportunity, I suppose.
You'd like to what? I'm sorry.
I'd like to give Paul that opportunity. Let's do a deep
Right.
dive. Let's
hear it.
conceptualize the solution that can solve this problem.
Yeah.
And I'll use my roles in the NHS to open whatever doors I can for you.
Okay. That's a
yeah.
great offer.
Yeah. Just
Thanks
so
very much.
you know, I sit on the Finance and Investment Committee of an ICS that's in deep doo-doo. And I've read 3 consultant reports that are just scratching at the edges rather than really transforming anything. We are wedded to one of the traditional system providers for the foreseeable future. So finding an overarching conceptual solution that is agnostic of any incumbent system would be really helpful.
Okay.
I have a position of influence there as well, being on the oversight committee for the implementation. Yeah, so the offer is there. Let's do the deep dive. Let's give shape to this.
Okay.
And I'll do what I can to open the doors I can open.
Fantastic. I've just put my email in the chat there, Lloyd.
So look,
Reach out to me on LinkedIn. That's the easiest way. I'm dead easy to
Okay.
find.
well, the thing is, I'd like to just open it up rather than,
Yeah, let's open it up. Yeah,
rather than
have
having
it one-to-one.
point-to-point conversations. What
Yeah.
I'm going to do through this group is invite the people that have attended and the other members of the group who couldn't attend to join in what we've called so far a deep dive. But anyway, a further conversation. I think what's been very gratifying to me from this session, and I thank you all for your time and contributions, is that I think we have found some common ground in respect of frustration and agreement that something important here is broken, and we all have a desire to try and fix it. So if that's all right, I'm going to offer to try and get us together again and to have a round table or a workshop, whatever we want to call it. But I think important to listen because we've all got ideas, right? And what would be great is if we can link arms and, try to generate some little force that can move things forward in a positive way.
Yeah.
Is that okay with everyone? So for now, kind of end of the debate and conversation, if you could just hold on that. I know you've all got ideas, to contribute to this important topic. We all feel strongly about it. So I look forward to carrying on the conversation and maybe, taking advantage of what Loy's offered, which is to have a locus where we can develop a pioneering model. Yeah.
Yeah, sounds good.
I really enjoyed that. Thank you so much for your time and your contributions. Thank you, Tom. Thank you, John, and thank you everyone for joining today. We'll be in touch soon. Is that okay?
Mm.
Have a great weekend, everyone.